Dear colleagues, dear moderator, in the next minutes, I'll talk about the importance of the electrocardiogram in the setting of acute coronary syndrome. And I will go with you through the many issues regarding the use of ECG in the setting of ACS. Now, new onset chest pain is a big problem. We know that it does represent the most frequent admission diagnosis in the emergency department. However, not all acute chest pain are acute coronary syndrome. Indeed, half of them will have a cardiac cause, and 5 to 30% of them will turn up to have a final diagnosis of acute coronary syndrome. Thus, acute chest pain does not equal acute cardiac ischemia. But if an acute coronary syndrome is ongoing, patients at highest risk must be identified as soon as possible as they benefit the most from timely and more aggressive therapies. In the ACS diagnostic algorithm, we first have physical examination, and soon afterwards we have ECG, which comes before then any biomarker and imaging tool. Thus, why ECG in the contemporary era? Well, ECG is the first point entry. And look, being the first point entry, it provides a great prognostic implication to the physician. So we look at the patient, we look at the ECG, and we can figure it out the 6-month patient mortality going from T-wave inversion, moving to ST segment elevation, and ending up to ST segment depression. And this first point entry is costless, harmless, rapidly available, and easy to interpret. First point, ECG in ST elevation MI. ECG in STEMI patients is critical. It's the key. It leads to the treatment. We know that every 15 minutes delay from door to balloon, we lose 6 patients every 1,000 treated patients. So we need to hurry. We need to rush. And the only way is to make the diagnosis as soon as possible. First major issue, we need to be specific. And why is that? Because still, patients with acute chest pain and current ACC or European criteria, which are 0.2 ST elevation in right precordial leads and 0.1 in all other leads, still these patients, up to 30% of them, may not have an acute myocardial infarction, and we may make a false positive call to the cath lab. So we need to be specific, and how can we do? First, we have to look at other ECG abnormalities. Look, only the minority of patients, nearly 10% of STEMI patients, present with an isolated ST elevation. Indeed, those are namely patients presenting very early from symptoms onset. The great majority of STEMI patients present with an ST elevation, but also with coexisting ST, T, or Q waves abnormalities. But the most important thing is the presence of reciprocal depression. We have to look at the ST elevation and look at the presence of reciprocal depression. In this landmark study, Otto demonstrated that if we associate to the ST elevation the presence of reciprocal depression, the specificity goes from 81 to 99%. And what is more impressive is that the positive predictive value doubles, going from 50% to 94%. So chest pain, ST elevation, look at other ECG abnormalities, but more importantly, look at the presence of reciprocal depression. Second point, we need to identify high-risk patients. We know that anterior MI patients are those at highest risk, and the ECG can help the physician to figure out the site of LAD occlusion. In this study, the authors correlated the electrocardiographic alterations at presentation in first anterior MI patients to the angiographic findings, and what they found was that the presence of an ST elevation more than 2.5 in V1, the presence of right bundle block, and the presence of an ST elevation in AVR, they fairly good were associated to a capillary lesion proximal to the first septum, while the presence of an ST depression in AVR was associated with a Kaplan lesion distal to D1. So my guess is that when we have an anterior MI patient, we need to look at two leads, V1 and AVR. If in V1 there is an ST elevation and this ST elevation is higher than AVR, we're talking about probably about a Kaplan lesion in the proximal LAD. On the other hand, if the ST elevation in AVR is higher than V1, we're talking about a Kaplan lesion in the left main or a proximal LAD in the context of a three-vessel disease. In both cases, what we can say is that the patient has a high risk of cardiogenic shock. And this is just by looking at the ECG, not looking at the patient, not looking at the heart rate, blood pressure, peripheral perfusion signs. We look at the ECG and we know that the area risk is big and the patient has a great chance of going to a cardiogenic shock. The third major issue, which I guess is one of the most important, is that we cannot miss the diagnosis. We know that every 15 minutes we lose 6 patients every 1,000 treated patients, so we need to make the diagnosis. And look, these are the odds of having an acute myocardial infarction if the ST elevation are present in each lead, and look at posterior leads and right leads. Their odds are pretty much the same than the other leads. And look at V9, 21. V9 has one of the highest odds for an acute myocardial infarction. So if we have an acute chest pain patient and the chest pain is ongoing, we need to look at the 12 lead ECG, but never forget to perform posterior and right leads. And it's not surprising that in 1999, Matesky found in 33 consecutive patients with acute chest pain at normal or non-diagnostic ECG, well, all of them, nearly all of them, 97%, had a posterior MI, posterior ST elevation, and all of them had alterations, echocardiographic alterations at the level of the posterior wall. And we all know that posterior MI patients do not have a so good prognosis. They might often have heart failure due to mitral regurgitation. So these patients need to be identified and they have to be sent as soon as possible to the cath lab. But if we do not perform the posterior leads, we miss them. Then I think there's one last rule which is critical in ST elevation MI patient, is that if we are in doubt and the patient still has acute chest pain, we need to repeat the ECG. This is an ECG of a 22-year-old male coming to our emergency department with acute chest pain, ongoing chest pain. The first ECG does not show any ST elevation, while just waiting 5 minutes later, peaking T waves in inferior leads come up, and the presence of reciprocal depression come up to the high lateral leads. And 5 minutes later, the ST elevation finally arrives, and we send the patient as soon as possible to the cath lab. So another important thing is that the presence of reciprocal depression may come before than the ST elevation. So both things are critical in ST elevation MI patients. Second point, ECG in non-ST elevation SES patients. Well, look, in the era of a multi-marker approach, troponins, creatinine, clinical factors, still the presence of ST segment depression is the most important predictor of 30-day death, 30-day death MI, and 1-year death. And look, we now think about troponins. We know that troponins stratify patients pretty well. And we often get a call from the emergency department saying, I've got a patient, he had chest pain about 3 hours ago, and now he's fine. And probably our first question is, how is the troponin? Well, my guess is that our first question should be also, how is the ECG? As the presence of ST segment depression may stratify even better than troponins. But probably our question should be, how is the ECG and how is troponins, as they both have a complementary effect. effect. So we have an SCS patient. We always have to ask about the ECG at presentation and also on troponins. Now, the two major issues in ECG of ACG in non-ST elevation SCS are first, some of ST depression. Look, those are data coming from two big trials, Paragon A and Gastro 2B trials, so thousands of enrolled patients with acute cardiac ischemia. And the higher was the sum of ST depression, the worse was 1 year mortality. So if a patient presented with an ST depression more than 2 millimeters, the all sum of ST depression, probably his prognosis at 1 year is not so good. And the sum of ST deviation is important also because it identifies patients who benefit most from an invasive treatment. These are data coming from the FRISC-2 trial, and patients with an ST deviation more than 3 millimeters, considering all leads, they benefit most from an invasive strategy. So if we have a patient with an ECG presenting an ST deviation more than 3 millimeters, we cannot treat him with or her with medical therapy, but we need to send the patient to the cath lab as mortality drops. And why ST deviation is so important? Because the higher is the sum of ST deviation, the higher is the chance for having a 2-3 vessel disease or left main disease, which means a great ischemic burden, a great atherosclerotic burden, so a higher chance, a higher risk for cardiac dysfunction and a worse in-hospital course. And now there's a question that is important, which is there a threshold value between the sum of ST segment depression and the number of cardiac events, namely heart events, death, and MI? Well, the answer is no. There is a linear relationship between the sum of ST deviation and the number of cardiac events. And even 0.1 confers a higher risk to the patient. So we need to look carefully each lead and look at any ST deviation. Even 0.1 is important as it translates into a worse prognosis. And then the last major issue in the ECG of non-ST elevation SCS patients is the forgotten lead, the AVR lead. This is often neglected, but if an ST elevation is present in AVR, especially if associated with ST segment depression in other leads, that's a bad sign. And why is that? Because the higher is the ST segment elevation in AVR, the higher is the risk for having left main or a 3-vessel disease. And look, if the ST elevation in AVR is higher than 1 millimeter, well, 1 or 2 of the patients will have a left main or a 3-vessel disease. So it's not surprising that in non-ST SCS patients, the presence of an ST elevation in AVR is the most important predictor of in-hospital death, right infarction, angina, and heart failure, more important than any other ST segment depression. So AVR is critical for prognosis. And the higher is the ST elevation in AVR, the higher is the in-hospital mortality. This is really interesting. Look, in this study, the patients investigated about 1,000 non-ST elevation MI patients, and they stratified their in-hospital mortality according to the Grace 3 score. Then they said, well, let's have a look at what happens if to the Grace 3 score we include the presence of an ST elevation in AVR. And look, mortality dramatically rises. But what is really interesting is that have a look at high-risk patients without an ST elevation in AVR, 7.1 in-hospital mortality. Now, have a look, intermediate high-risk patients with an ST elevation in AVR, they have a worse in-hospital mortality than high-risk patients. So the presence of an ST elevation in AVR re-stratifies the patient's risk. This is with the GRACE risk score, pretty much the same thing with the TIMI risk score. Look at low-risk patients. Patients at low risk with the TIMI risk, but an ST elevation in AVR, they die 18 times higher. And look, patients at very low risk, negative troponin is negative, good heart rate, good blood pressure, no heart failure, young patients. Probably those are patients that are not even admitted to the CCU. Troponin is negative, no heart failure, no signs of peripheral hypoperfusion, no arrhythmias. Look, if an ST elevation is present in AVR, their prognosis is completely different. So if there is a patient with an acute chest pain, always have a look at the ECG and never forget the AVR lead. So coming back to the beginning, ECG in the contemporary era, so we can say also is a great diagnostic and prognostic tool. It has therapeutic implications, but then there is one last final question. Does the ECG tell the physician all? Well, unfortunately, no. We have two main problems. First, confounding ECG patterns. Data from the FRISC-2 trial, up to 23% of patients with an acute coronary syndrome may present with a confounding ECG pattern, left bundle block, right bundle block, pacemaker rhythm. And look at the prognosis. Patients presenting with a confounding ECG pattern, well, they have the worst prognosis, whether we treat them with medical therapy or we send the patients to the cath lab. And look, their prognosis is almost double than patients coming with a more than 6 millimeter ST segment depression. So those are patients at high risk. And Brody, in 2005, investigated which were ECG patterns most frequently responsible for human errors. First place, left ventricular hypertrophy. Second, left bundle block. Right bundle block, pacemaker rhythm. So if we have an acute chest pain patient presenting with one of these ECG patterns, probably the physician needs to pay more attention to the patient and does not have to think directly that alterations are secondary alterations due to the pre-existing abnormality. And the second point is normal ECG. Up to 8% of definite MI patients may present with a normal ECG. And look at the survival curve. It's not linear. Patients with a definite MI and normal ECG die. And it has been shown that patients with normal or no significant STT changes at 1 year, they have the same prognosis of patients presenting with inverted T waves. And look, this is a Brazilian registry that showed that patients presenting with a definite acute coronary syndrome and normal ECG, well, at 1 year, we lose 5% of them. So ECG is important, but just looking at the ECG, we might miss some SCS patient, and we might miss some high-risk SCS patient. So concluding, we can say that the ECG remains the most immediately accessible and widely used tool in acute coronary syndrome with a striking diagnostic, prognostic, and therapeutic relevance. In ACS, ECG is critical for treatment decision, and both in ST elevation MI and non-ST elevation SCS, the sum of ST segment deviation as well as the number and type of involved leads, namely AVR, are strongly associated with prognosis. And the final point is that, however, SCS patients may present with a confounding or normal ECG pattern that is still predictive of a poor prognosis. Thus, in these patients, other diagnostic tests are needed before discharge him or her from the emergency department. Thanks.